Good morning, everyone, and thank you for joining us. A very warm welcome to Dr. Fernandez and to Vanessa. And so for today's webinar, the context is about healthcare. The context is that unplanned urbanization, especially in India, has rapidly expanded, and it has led to dense slum populations where healthcare disparities are really dire. And in these communities, maternal mortality remains over 113 per 100,000 live births, and neonatal mortality accounts for about 60% of all infant deaths. And we also have seen that malnutrition has affected more than 35% of children under 5 in urban slums. Now, at the Institute, at the Frost Sullivan Institute, we really believe that healthcare is a right. It is not a privilege. And that's why we are trying to accelerate innovation to zero to tackle global priorities like equitable healthcare access, driving initiatives that create real and scalable impact. Now, keeping that in mind, we are really honored to have with us Dr. Armida Fernandez, a pediatrician and co-founder of SNEHA Foundation. She is also the recipient of Frost Sullivan Institute's a Visionary Leadership Best Practices recognition for 2025. Dr. Fernandez has successfully redefined healthcare accessibility by creating a scalable community-based model that embeds services directly within urban slums, transforming the lives of women and children from lower income communities. Joining her is Vanessa D'Souza, CEO of SNEHA Foundation, who's been instrumental in expanding and strengthening SNEHA's holistic healthcare programs, ensuring that their sustainability and impact across India remains intact. Now, together, they bring a powerful combination of vision and leadership to today's discussion. So a very warm welcome to both of you, and I look forward to hearing your insights and hearing a little more about SNEHA Foundation.
Thank you, Prerna. Pleasure to be here.
Thank you.
Thank you, Prerna.
And
I'm grateful for the award to Frost Sullivan. So thanks so much for having us here on board.
Our pleasure. Thank you. So for today's discussion, we know that traditional healthcare often struggles to reach the most vulnerable. But Dr. Fernandez, your work has, exemplified a powerful shift toward integrated community-based. So what inspired you to transition from a distinguished career in clinical care to focusing on, community-based healthcare and actually bringing down neonatal mortality, at even one of Mumbai's largest public hospitals? Can you share how you did that?
So, I'm often asked this question, Prerna, why did I move from a hospital, a professor, dean's post, move into the slums of Mumbai? And to me, it was a natural transition because as a neonatologist in Sion Hospital, I had just one focus. When I joined as a lecturer, the neonatal mortality rates were embarrassingly high, almost 70%. And my professor, head of the department, said, why don't you just focus on bringing down neonatal mortality rates? And really that struck me, was ingrained in my heart, and for decades, that's what I was trying to do, bring down mortality rates and decrease the rates of, improve neonatal health and that of their mothers. What happened was when I worked in Sion Hospital, I realized we did bring down mortality rates. It was most rewarding. But finally, after some time, I had some problems. The mortality rate of really even 600, 700 grammars fell. We discharged them went home. But I realized that many of them didn't come for follow-up. I was wondering, why haven't they come for follow-up? And then I realized that many of them probably died in their homes. They went home and died in their homes. The second thing I realized that we still continue to have high-risk mothers come very late in labor. So when they came in late, either the fetus died in utero, what we call a stillbirth, or many of them had severe asphyxia. They couldn't breathe and either they died of it or they had long-term morbidities like cerebral palsy, things like that, which they didn't want to bring their babies to the hospital. So even as a professor, I decided we need to find out why they don't come and what we can do about it. And one of our programs was in the New Delhi slums where we went into the slums to talk to these women, find out the causes. And once we did that, it was sort of a transformation. I realized where they live, the families, their homes. You just see the informal slums, the picture you see here. And then when they went home, how did they feed their children? How did they look after them? You know, it was a very challenging method. And as we worked more, I realized that there could be a change if we talk to them, if we convince them. And that's when I realized that if we really want to tackle mortality and health of newborns and mothers, you just can't work in hospitals and intensive care units. You also have to move into their homes, into their communities, into their slums, work with them, and bring about that change. The second thing that added to it is during one of our neonatal mortality meetings, we had a 6-week baby that was brought and was raped and succumbed. And that time I realized that again, what was I doing in the hospital? We have to move into the slums and prevent such things. And therefore, when your heart changes and when you say, I must do something about it, I need to move, God shows you the way. That's when the thoughts, my desires, dreams for working in the slums resulted in starting the Society for Nutrition, Education, and Healthcare, and that was SNEHA. So that's the reason I moved from one area to another.
Wow, that's quite hard hitting. I think all of us on the panel being women, it does hit a nerve. But thank you, Dr. Fernandez, for that. Vanessa, coming to you, you made a transition to the social sector after 21 years in banking. So what really inspired that change for you? And were there any factors that you wanted to share that enabled your transition?
So I think, I never ever thought I would move into the sector, Prerna. And Dr. Fernandez actually asked me to come and volunteer over there to help with fundraising. And I did that for about a year. And I think for me, the first site visit was a walk deep into the slum of Dharavi. And most of us have heard of that slum. As living in Mumbai all my life, I had driven past it. I had never ever walked deep in. And at that time, SNEHA was running one of the largest urban malnutrition programs in India. And we were going to a daycare center. And I naively thought that, this daycare center, I would see these nice, bubbly, bouncy kids. And I think what I saw really disturbed me. I saw that, these kids could barely sit. They were very, very listless. And the living conditions of the people deep in these slums was so abysmally poor. And I think that hit me because, I worked just 3 to 4 kilometers away, and I didn't know that at that time, over 30% of children were actually in a state of malnutrition. So I think that kind of disturbed me, and I decided to volunteer, and I volunteered for 2 years. And of course, then at the end of 2 years, Dr. Fernandez asked me to take over as CEO. So it's been now 12 plus years, Prerna, that I've been running SNEHA.
Wow. That's amazing. And I think sometimes you just need that watershed. And I like, Dr. Fernandez was saying that once your heart changes, then, nothing can really stop you. So moving on, to the next section of the discussion on empowering communities and sustaining change. Sustainable impact, in urban health, it actually demands more than just medical intervention. It requires understanding the needs of public health and genuine community ownership and adaptable strategies. So, Dr. Fernandez, just coming to you. How did your role at Sion Hospital, both as professor and as dean, shape your approach to public health and community engagement?
So I think that experience is something I just loved. If I look back, I'd like to be a professor. I'd dean of science or hospital in my next life, like the Indians believe. But as professor of a science hospital, and like I said, that we had very high mortality rates. We had to bring down, and I was talking about 5 decades ago, so it's a long, long way off. But at that time, babies were literally dying, and we needed to know what is the cause of death. And what we realized that the cause of death was one of the causes, not all the major, but one of the causes was infection, and that we had to bring down infection. Now, in a hospital at that time, the problems were that babies were dying, but we did not have the finances, that especially for neonatal care, to buy any equipment to add any additional staff. We had just one nurse, no equipment, and therefore you had to sort of break your head against the wall and said, how can I bring down mortalities without nurses, without equipment? And today, of course, breaking your head is called innovations. I realized that much later. But we looked at innovative ways. I won't talk of all of them. We've used a lot of them. But one thing that I did, Prerna, and that was, the one of the causes of death was babies developed diarrhea, and they got septicemia and they died. One of the reasons. So I focused on that. I looked at that. I said, what can I do? And I realized we were using formula feeds. We didn't have enough. We often diluted it with I don't know what water. But there were bottles that were being used, not properly sterilized. And then practically overnight, I changed the policy. It wasn't a popular policy, but I said, we will stop formula feeds, we will not use animal milk, and we'll break all the bottles. So from then, so what was the alternative when you don't have money? And I said, of course, we'll use human milk. And therefore, I got all the mothers into the unit, got them to feed their babies. And they fed their babies. And therefore, I had to change the second policy. The policy in the unit was no entry of visitors, including the mother. I said, no, every mother will come and feed her baby. The third problem was we had no nurses. And I remember giving talks on it. I said, of course, we have enough nurses. Every mother is a nurse. And what better nurse than a mother? The nurse that we had did all the procedures that the baby needed, but the mother cleansed the baby, held the baby, breastfed the baby, expressed milk when the baby wouldn't feed. And today, the changes, all that we did is being followed all over. That there's free entry of mothers. People are now using exclusive human milk, and that non-nutritive sucking, kangaroo mother, all these came up as research and programs that are followed all over. But finally, what I did was to ensure a continuous supply of safe human milk. In 89 years, literally a few years later, I started the first human milk bank, not only in India, Asia. It was a huge problem to start it. It was even a question in Parliament. But I said, I must make sure every baby will get that human milk. And it took me a lot of trouble, but I did that. And since then, every baby got a human milk. And today, human milk, they're mushrooming not in India, across India, many, many years later, and people know the need and the utility of human milk. So these are things that I did to bring down the mortality. But as professor, I realized that if we brought down mortality in Sion Hospital, we could do it in other hospitals as well. So we asked for permission, and in the 56 hospitals that were government hospitals, not a medical college, we went and trained the staff. And I realized that people were willing to train, they were willing to learn, they were willing to change. That is one learning I had as professor. And finally, as dean, what did I realize as dean? I realized the strengths and weaknesses of the system, how there was a need for people from outside, NGOs from outside that could help improve the quality of the system. And therefore, when I started SNEHA, I knew that we could work with the system. But the most important learning, I think, is that we work with them we need to have them trust us. That's extremely important, Prerna. And that's what they did. They realized that we were there to save lives. We wanted to help. We were not there to collect data and give it to the press. Many some people do, and once that trust is built, then the system is willing to work with you. I think these are the learnings when I was both professor and dean.
I think you preempted my next question, Dr. Fernandez, because it was what is the one significant shift that's needed to, achieve urban health equity and especially in marginalized communities. So you did mention trust, and I think that's extremely significant. But is there anything else, that you believe is required so that we can achieve this urban health equity?
It's difficult to point out one, but if you ask me to choose, the single most thing that needs to be done to provide health equity is to have the health finances that are given to give a large proportion of it for primary health care. Now, when we talk of primary health care, we're talking about preventive care, promotive care, and then curative care. And we need not just more finance to do it, but we need a better quality of primary health care. So we are talking about we need safe drinking water, we need proper sanitation, immunization across all ages for all diseases. And then we need to work on maternal newborn health, have health at their doorstep, which we can save people's lives, prevent malnutrition, detect it early, treat it early. All this can be done with primary health. And I think when we say quality primary health, is one thing we need to remember, Prerna, which people don't. You might have systems, we might have equipment, we might have staff, but the way they treat the staff, the poor, that is extremely important. The vulnerable must know that we're not doing it because they are free services and therefore they can access their fee. It hurts them. They say we have to go to this service. If we had money, we would have gone to the private sector. But when we have quality services and treat them with respect, and we have a lot of experience with that, we use AI. When you treat them with respect, then I think we can bring about a lot of change. Health equity. I must say that before I finish this, talking to you, that the government is trying very hard to improve health equity, and I must give it credit. For example, they have a Janani Suraksha Yojana, some programs to improve the health, and in this they actually incentivize women to deliver in hospitals. In the past, many women delivered at home, especially rural area, and even people who recently moved to the urban slums, and that increased neonatal maternal mortality. So they incentivize them with money. They delivered in the hospital, they would pay money. They also have now insurance schemes that they've insured people against for hospitalization. That was the most expensive thing that moved you from middle class, from poverty to below poverty. Unfortunately, although we have all this, they have to be changed. People must utilize it. They must understand it, and then we have to make sure that, and that's something else that SNEHA works on. Make sure they know how to access the scheme and make the most of it. I think
Great.
that's, yeah.
I mean, like you said, I don't think there's just the one thing or one shift, but several, and it's heartening to know that the government is taking action as well. Vanessa, my next question is for you, and it's just to understand SNEHA a little more. So, how does SNEHA's integrated model, combine health and social intervention, and what is this model for sustainable change?
So, Prerna, when we started, like Dr. Fernandez said, we started working with pregnant women, with newborn babies, and on domestic violence, completely different areas, at the time. But what we realized over a point of time is that, the women would deliver in hospitals, they would deliver healthy babies, but babies would slip into malnutrition as they went, over the months, specifically at the time of 6 months when they're supposed to introduce complementary feeding. Many of them didn't know about good nutrition practices for children. So we started then working on malnutrition in children. We then simultaneously realized that the anemia of pregnant women was very high. In order to address anemia in pregnant women, we needed to start working with adolescents. And therefore, we started an adolescent health program. So, everything started in a sequential manner. And then we realized that in one home, why not provide all services? And that's how the integrated model really started. So the integrated model addresses the critical points in the reproductive life cycle and the life cycle, actually. So we start with preconception care. Before the woman gets pregnant, the minute she says, we do a monthly menstrual menstrual surveillance, the woman says she wants to get pregnant, we make sure that she's healthy, her addresses anemia. Then we work through the pregnancy period. Then the child is born, so we'll work on institutional delivery, immunization, addressing child malnutrition, child illness. Then, of course, there is the adolescent period where we work on physical, reproductive health, gender-based violence, as well as civic engagement. But across all these ages, working on gender and gender-based violence is very critical. And we've actually seen data where we've seen association between mothers who experience domestic violence having higher levels of stunted children, having lower levels of contraceptive uptake, clearly indicating that her caregiving abilities and her agency are impacted by domestic violence. Now, while we work on this integrated model, we make sure that the public systems, that the respective public systems, so if it's nutrition, it's the Integrated Child Development Services, also called the ICDS. If we're working on health, then we have the municipal corporations address health. When we're working on domestic violence, we work with the police, with the District Legal Services Authority. Because the idea is, how do we make sure that the public system, the services are available to these most vulnerable sections of the community? So this really is the continuum of care approach, which we do with the public system as well as with the community. Now, you'll wonder, how do we show impact, right? Because these are multiple touch points for the community. So every single focus area we work on, we have impact measurement. So for example, if we're working in, and this is a specific program, and I'm sharing data from baseline to end line, this is in one of the vulnerable communities we worked in. If you look at the first box on maternal health, these are maternal health indicators, modern contraceptive prevalence, so that she can space children. She has agency to decide when she wants to have children. Early registration of pregnancy, so that she can, start the whole, the antenatal care early. And similarly, we have anemia as well as dietary diversity, maternal dietary diversity. Similarly, if you go to the child side, exclusive breastfeeding, complementary feeding, minimum dietary diversity, and minimum acceptable diet, each of these indicators is measured in the intervention. Then we also look at the actual end outcome. So you have 3 forms of malnutrition: stunting, wasting, and underweight. And you can see that both stunting and underweight have reduced baseline to end line, whereas wasting has actually remained in the 12 to 13 range. And the fourth graph, I think, is really important. This, we talked about working with public services. Now, it's important for us to measure how these public services are being used by the community. So if you see the first one, received any ICDS service, that means any nutrition service, we've actually seen the percent of women accessing these nutrition services and has gone up to 96%. Similarly, the ICDS taking anthropometry of children has increased from 79 to 87, which means we know not only is the community accessing the service, the public system is also providing the service. Similarly, if you look at the health services, and of course, immunization being an important outcome. We now move to the adolescent stage. So I'm only sharing 2 indicators. We have more of all these, but just to give you a sense, 2 important indicators are, how are the gender equitable attitudes of adolescents changing as we work with them? And you can see from baseline in 2021 to end line, the number of adolescents with high gender equitable attitudes has actually increased from 52% to 72%. And these are all done with survey tools. And again, we work on BMI and anemia, and you see that has reduced. And the last area is reducing violence and improving mental health. Here also, the 65% of survivors who have availed SNEHA's counseling services have reported reduction in violence. 76% where we've worked on anxiety have reported lower levels of anxiety. And 72% where we work on depression have reported lower levels of depression. Yeah. Now, the challenge we were now faced with, Prerna, is, we have all these discrete measures, but when you work in a family, how do you measure the family's overall improvement in health indicators? Yeah? So for this, actually, we worked with the Pfizer Global Foundation under a volunteer program, and we came up with what we call the Family Health Index. So saying that if I have multiple interventions in one family, is that health-seeking behavior of that family really better than a family where maybe I just work on one area? So we came up with this index, which has 11 parameters. The first 3 are key health outcomes: malnutrition status of children, anemia status, and well-being, which is the mental health status of the woman. And then we have another 8 intermediate health outcomes, which is anemia, early registration, antenatal care, which are a lot of process factors. But I want you to look at the 11th one. I think the 11th is really interesting. It is male involvement in maternal, child, and reproductive health. Because male engagement is an important part of our intervention, knowing that in these vulnerable and low-income families, the men are typically the decision makers. And we've also wanted to see that if we engaged men more, would the health-seeking behavior of the woman improve? So we decided to test this family health index, and we tested in one program intervention area. And at baseline, you can see, so we have a family with low health status, moderate, and high health status based on the indicators on the previous slide. And we see at baseline, 38% of women had of families had low health status. But 1 year later, on the annual survey, that has reduced to 31. Moderate has actually increased from 42 to 46, and high improved from 20 to 23. And this is actually better seen in this graph, where the solid line graph is the baseline, where you can see, number one, there is a lower health status, but also the distribution is much larger away from the median, compared to the graph on the right, which is the dotted line, which is the annual survey. You can see not only is a rightward shift of the graph, showing that there is better scores, but we also see that the distribution around the median is much lower in the right, showing that overall there is much better health status in the community. So this is one of the ways in which we have now started looking at the Family Health Index as a means to address the overall change in the health indicators in a family.
Yeah, that's very comprehensive. And I think, yeah, what gets measured gets done. And, it's also validation of all the good work that you're doing. But I think this is on the one side, but as part of SNEHA, you're also empowering women as, community health workers. We would love to hear a little bit about that.
Sure. So actually, there are these informal settlements are so large, and there are so many of them. So we thought, how do we ensure that the work we do, we bring about these great results, but what happens if we exit the community? And actually, one of our interventions, we learned from this mistake. We did the first urban health, the malnutrition program in Dharavi, and when we exited the area, we didn't prepare for the exit. We saw wherever malnutrition had declined to below our target, we just left the area. But when we came back later into the same area during COVID, we found that, malnutrition levels had gone up again. So we said, this model doesn't work. How do we create a sustainable model? So we actually have 3 stages that we look at in any model. Yeah. The first is what we call the direct intervention stage. This is when we first enter a community. We create this evidence-based model of, it could be malnutrition, it could be adolescent health, could be domestic violence, violence prevention. While you're creating the evidence-based model, you're not only improving the health outcomes, you're also building trust in the community. And women in the community who experience these services want to then come and partake and help in their communities. So we then start identifying and enrolling these community volunteers and giving them intense training, technical training, soft skill training. So at the end of the period of direct intervention, which is typically about 3 to 4 years, we have this cadre of trained and engaged community volunteers. We then feel comfortable enough, and our health indicators, baseline to end line, is improved. So we feel more comfortable moving to the next stage, what we call the indirect or the hybrid stage. Now, this stage is a stage where we have about just 50% of the SNEHA frontline workers, but the rest of the people on the field are the community volunteers and, of course, the government frontline workers, because training of government frontline workers is core to our work in every stage of the intervention, direct, hybrid, or sustainability. Now, in this hybrid stage, we find that we get the community women to do activities like mobilizing for anthropometry, immunization, home visits, organizing group meetings. The important thing is they begin to be accountable for their own communities. They begin to understand that if there is a case of domestic violence, we have to intervene and we have to help the woman. We have to accompany her to the police station. So you begin to create this cadre of community volunteers that are empowered, informed, and connected with the respective public system to demand quality services. And finally, the last stage is where it's a very low touch stage, where we transition, we are at a stage where we're ready to transition out of the community. Very, very low touch points for SNEHA, but high touch point for the community volunteers as well as the government frontline workers. So we have about 6,300 community volunteers who give about 2 to 3 hours in a week for health in their community, violence prevention, adolescent health, civic engagement. So today, while they may be trained on nutrition, they also know how to write a letter to the municipal corporation if, say, a drain is not cleared, or if water supply isn't available. So agency has been built in multiple ways. Now, the important thing is, when you build these models, how do we ensure that impact continues to be created? So if you look at this graph on the left, this is to share with you how stunting, underweight, and wasting has performed in a direct intervention model where SNEHA has intervened. If you look on the right, this is a hybrid intervention model, and you can see that we're still able to bring further reductions in both stunting and underweight, relatively less, but definitely some more. And this is with community volunteer engagement and the government frontline worker engagement. So what we really have been able then to build is a strong cadre of community volunteers. Another important indicator for us to check if our model is working is the uptake of government services. So on the left, you can see in direct intervention, this is typical of any community we enter. Now, we find about only 40 to 50% of women are accessing public services. At the end of direct intervention, we see over 90% of them are accessing both health and nutrition services. But what's interesting is in the hybrid intervention stage, not only they continue, they also increase utilization of public services, which means the volunteers are ensuring that new entrants into the community are being connected to the health and nutrition services. And you're creating a model that is actually then sustainable. Simultaneously, the public system is also ensuring that they are providing services. So both quality and coverage of services has improved. And this is really how we've been able to create a model that is sustainable, that is being run by community volunteers and the government with very minimal touch point by SNEHA.
This is, I think, extremely sustainable on the one hand, but it's inspiring as well. Very inspiring, Vanessa. And I know that, you're doing it in Mumbai, and I really sincerely hope that, this can be taken to other countries as well that are facing similar challenges. So I think I will hand it to Hannah. She is going to run a poll question for the audience, and then we will resume our discussion.
Perfect. So I have launched the first poll question, and it should appear on your screen. Okay, and for our panelists, you can close the poll on your screen by pressing the X button. And for LinkedIn viewers, the poll question and answer option are shared in the comment section, and you can simply reply with your choices. 1 second, let me send the question. Okay, done. All right, the question is, can Frost & Sullivan be your transformation partner? You can talk to our expert to dive deeper into transformational strategies and explore specific needs within your company. Or you can join Frost & Sullivan's Growth Council to gain access to think tank that focus on transformational growth strategies, or designate your company as a company to action to increase exposure to investors, mergers and acquisitions opportunities, and other growth prospects. Or lastly, you can become a Frost growth expert in your area of specialization and share your expertise and passion with the community through our think tank. So I will leave the poll open for 10 minutes. Once the webinar concludes, the Frost & Sullivan team will follow up to discuss your responses.
Thank you, Hannah. And of course, for all of you listening in, if you would like to connect with SNEHA Foundation, of course, we have Vanessa and Dr. Fernandez, but you can also reach out to the Frost & Sullivan Institute, and we would be very happy to put you in touch with them. If you would like to, volunteer, do some work with us, then please do reach out as well. All right. Resuming our discussion, in the next session, Dr. Fernandez will focus on breaking our head or scaling innovation and measuring outcomes. So replicating, successful health models, Vanessa, that you just talked to us about across diverse urban landscapes has its challenges, especially when it comes to resources, partnerships, and policy. So, Dr. Fernandez, how do you envision SNEHA's successful model to be scaled to other countries?
Prerna, our experience really is what we have done in our city in the urban model, and depending on the issues you face, then you can take it to scale. For example, examples that Vanessa has given about malnutrition, about violence, and adolescent health, they could be taken across whichever country you are. But the referral model that we have worked on, you can be an example of people can use the way we worked our referral model, and we have taken it to scale, and then they can take it across other countries. And I'll tell you how we did it. The first really a successful model that we created was a referral model, and it is how the system works in Mumbai. So we have a large number of hospitals, but we started with what was called level 0. So level 0 are health posts that are situated within the slums or close to the slums. Now, they were existing health posts, and I'm sure it is in countries across the world. Something exists, but they're not being utilized. So these health posts were meant for maternal newborn health, but during the pulse polio program, there were a change into immunization centers. So when SNEHA looked at that, and we were focusing on maternal newborn health, we talked to the administration and said, can we pilot maternal antenatal postnatal care for women in the slums in these areas? And what we did, there was a total of 176 in the city lying there, not being utilized to the best they could. And we took a few of these health posts, that is the bottom line, the base level 0, and we started functioning them into antenatal postnatal. Ensure that it was a safe environment for doctors and nurses to sit in. They had all the equipment needed for antenatal and postnatal services. And when these were successful and we presented it to the system, then this could scale across the city to the 176 health posts, not only in our corporation, later on to other corporations. So that was one thing that we did. The other thing is the reference system we created, and this picture is there to show you how the reference. You have different levels of maternal and neonatal services. For example, at level 1, you have the maternity homes where they just have maternity services. You can go there, deliver your babies, and therefore you can only look after normal deliveries. So that's level 1. The level 2 is where you have other services, medical, maybe medical, you have surgical, often. So you can have a second level of deliveries that are not too complicated at level 2. And finally, you have the tertiary level where you have intensive care facilities available. And therefore, all the complicated cases, the high risk mothers should be there. Unfortunately, in the city, despite the structure, as I said, health posts were not functioning, and normal mothers went to the tertiary institutions over, overcrowding there, and mothers came to the primary, the level 1, and sent, instead of being sent to the level 3 because it was a serious, complicated case, they sent it to the level 2. And therefore, mothers sometimes lost their lives, or there were more complications in this mother. So we decided to create this model, and what we did was we worked with the system, a very participatory approach, where we worked with the doctors, nurses, administrators to improve the quality of care and the buy-in. The participatory approach was the buy-in, and I think this is something people should learn. When we have ideas and we want to sell it, we go there and say we know it all, and therefore you have got to do it. But SNEHA's participatory approach is, what do you think are your problems? How do you think you will solve it? So they feel it's their program and they are getting the solution. We are just, there to help them. We are catalysts actually in the program, and that's what we were. So after training them, we ensured quality of care needed at each level. So that was what we did to start with. And then we started the referral project, and we made sure that patients the training, and then there was documentation. Every case that was referred was documented, so they went to the site. So one could, at the end of the month, analyze which patients were referred, where they adequately referred, what finally happened to that patient. So this is what we did. And the results were, at the end of all the work, was we ensured that over 1 lakh pregnant women with complications were assisted through the maternity referral system. And we had actually trained over 6,000 public health facility staff. And these referral linkages, although the hospitals existed from 0 to 12 intra meaning at all 3 levels, and then seeing what we had done in the city, the surrounding municipal corporations asked SNEHA, they actually came, requested us, can you do it in our cities as well? And therefore, we went to the other 7 municipal corporations as well. And therefore, we were actually working with, at the end of 301 public health facilities across around 7 urban health. And the maternity referral system sustained. Finally, it was taken over by that's important. We showed them the way how it could be done. It was formalized finally by the government directives, and that was sustained by the public health system. They printed their own referral linkages, and documentation started in the system, and they actually created nodal officers to do that. So that was something that we did over the years and has been very successful. And as you can see, 92% of maternal cases are referred as per protocol. And of the health posts, 84% had all 9 core antenatal services. And this is how the referral system. So I would say, depending on what country you are, where your problems lie, you need to have a participatory approach, or work with the systems and ensure there is documentation. That's extremely important. Proper documentation, whatever innovation you want to create, and then you get them all together, and finally the system would then accept it and take it as their own. So I think this is something that, depending on what issues, and Vanessa talked about other problems, that are aspects that we are facing with malnutrition, that also can be taken to scale.
Prerna, I just want to add one small thing here. When you talk about scaling, taking the models to other parts of the world, a couple of months ago, actually, we launched the SNEHA Knowledge Center. And the objective of launching this is, we have this wealth of knowledge, information, protocols, frameworks, etc., that are available. And we wanted to make it available open source to other NGOs, government, etc., plus provide technical expertise through training, mentoring, capacity building of partner NGOs, as well as the governments. And this SNEHA Knowledge Center is really our platform through which we will scale impact.
Okay, that is wonderful. And, it seems fairly straightforward. I'm sure there's a lot to go through, but it's getting the basics right, from the model that you just described and making sure the documentation is right. So it's something that I really hope other countries can take and, using the knowledge center. And I'm sure, through the Institute, we would absolutely love to be associated with it as well. And with scaling comes, challenges as well as enablers. So, Vanessa, what do you think the biggest enablers have been in scaling SNEHA's programs? Is it, you did mention the government, but are there other organizations that you have worked with that have helped you scale?
So I think the first is our evidence-based approach. You can't work on urban health unless you're able to create models based with data to back them, showing the evidence. The second, of course, like Dr. Fernandez shared, a strong partnership with the public system. But the third, very important, is a deep understanding of the community. Communities are very diverse. Even if you look at Mumbai, there is so much diversity from one slum community to another. And unless you understand what are the drivers and the challenges of those women in the slum community and you help them negotiate it, you cannot bring about change. So I think strong community engagement and understanding of the community. And I think the fourth is the government themselves has been prioritizing and making a lot of improvements in public health. So whether it's the nutrition program, the public health, the police, you're seeing a lot more, positive, proactive approach by the government. And that is certainly, supporting the improvements. And last is we're seeing NGOs collaborating very well. I think the pandemic taught us one thing, Prerna, is that you cannot work without collaboration. So wherever we work in the communities, we partner with other organizations. In fact, our whole scaling model of the SNEHA Knowledge Center is built on the premise that partnerships are the only way forward. And sharing knowledge freely, openly is the way that we can all address these very protracted problems.
Absolutely. And ironically, COVID was a time of isolation, but at the same time, I think we realized how important, collaboration actually is. All right. So we have come to the end of the session, but in closing, I think it's been really enlightening to understand what all SNEHA does, and more importantly, the genesis of it. And this problem has not yet gone away, when it comes to maternal with neonatal mortality. And I think all of us are very inspired now to do our bit. But in closing, both my next question and last question is for both of you, Dr. Fernandez and Vanessa, that if our audience and listeners could take one action after today's session, what would you urge them to do?
What action I would, what action can one take? And I think you need to, at least in my experience, what you do, you must follow your heart. And it's not, you might have all the degrees in the world teaching you what to do and how to do, but that will bring about change, but in a different way. But therefore, you need to follow your heart. And sometimes you don't know what your heart is saying. So you must be willing to listen. It may whisper, you can see something that can move you. You can hear about something that you feel strongly about, and you feel it. Once you feel it, you must take that action. And don't expect that action to be something really great. It really doesn't matter. Once you listen, even if you bring about that change in just one individual, in that one family, in one community, when you do it the way you want to do it, that I think that change will make you happy. That it's not easy to be happy in today's days, but really make you feel really happy. And if you do it well, I'm sure if you can then scale it up to much larger numbers. So listen to yourself, move, let your heart move you, look, listen, and feel. That's my message.
Prerna, I think, coming from the corporate background, and I'm sure a lot of your audience are corporates, I think every one of us has some skill, some competency. And we need to think, if we have to address inequity in the world, there are so many ways we can do it. So bring your own skill competencies to organizations, volunteer on a consistent basis. I shared the family health index. These were a whole lot of people working in the corporate sector who just came together and helped us come up with something that is really valuable for us. So I would urge people to volunteer. When you volunteer, you find what really disturbs you. It also, I think, in many ways brings about a huge balance to your own life, that you begin to stop living in the bubble that you live in and get exposed to what's happening in the real world. So I would just say, step out of your comfort zone, volunteer. I can assure you it'll be a very enriching experience.
Absolutely. Thank you, Dr. Fernandez and Vanessa, for inspiring us. I think we've listened to what you had to say, and we are inspired to take action and to do our bit. So with that, thank you so much for your time, and it's been an absolute pleasure.